Bill McDonald, MD, is a partner with Hospital Pathology Associates, PA, a large multi-specialty pathology group serving Alena Health and other partners in the Minneapolis and St. Paul area. He assists several large neurosurgical and neurological practices, studies autopsy brains, and helps manage local neuro-oncology diagnostic and research interests. His principal goals are to apply the best available traditional and molecular tools to diagnostic neuropathology, to teach those with an interest in neuropathology, and to develop collaborative research projects in the study of pituitary adenoma and infiltrating gliomas. Other interests within the field of neuropathology include CNS infectious diseases, muscle and nerve pathology, and neurodegenerative disease. His current research applies statistical learning techniques in diagnostic areas that lack clear gold standards. Please go ahead.
Oh, golly, thank you very much. I'm looking to see, you can hear me? Yes?
Yes, we can hear you loud and clear. Yep.
Oh, fantastic.
Yep.
Fantastic. Well, thank you very much for showing up to this, and to the organizers for inviting me to talk about this. I don't have any financial relationships to disclose. Really, I think I might as well start up front with an apology. This is a controversial field, and there's likely to be things that I talk about today that assail certain cherished objects in the diagnosis of pituitary adenoma / pituitary neuroendocrine tumor. Right off the bat, let me clarify, I'll be using these terms interchangeably. I think the time spent on the simple nomenclature change from pituitary adenoma to PitNET is too much to go into today. But I'll be using both terms. And what I want to do is describe the special considerations that are necessary when you're talking about a classification that involves overlapping groups. Most of the time what we want are groups to be nice and discrete and to be bucket A and bucket B and bucket C. But we know, and we'll talk about this, that there's some porosity between the buckets in the world of pituitary adenoma classification. I want to talk about some of the important limitations in the current WHO classification, and then maybe some sources of ambiguity, some of the problems, with some solutions, evoking this concept of falsifiability and some of the machine learning tools that can help us understand and organize our thinking when it comes to this group of interesting tumors. I'm going to jump right over the demographics and the usual, these are common tumors. They're obviously common tumors. In my practice, there are probably 5 or 6 on the list behind things like the diffuse gliomas and the meningiomas and the metastases. And we'll get right into the structure of the classification itself. So they're obviously neuroendocrine tumors, and really differentiate in the fashion of anterior pituitary cells, non-neoplastic anterior pituitary cells. 3 big families. This is all well known, driven, as it turns out, by transcription factors including SF1 for the gonadotrophs, T-PIT or the corticotroph group, PIT1, the acidophil stem cell group, and the large group of tumors that produces prolactin, growth hormone, and TSH. But we know that unfortunately, or fortunately or unfortunately, we know that there is overlap between these families. And some of the most important work in the recent past to really underscore this are the identification of groups of SF1 positive, PIT1 positive tumors, for instance, last year by Dr. Musch in Hamburg, and even a group of sort of gonadotroph, corticotroph expressing tumors, phenotype tumors, SF1 positive, T-PIT positive tumors that Dr. Asa and colleagues have shown within the last year. So these links are hot, and you should be able to, when you have access to the PowerPoints after this presentation, you should be able to just follow these links to the PubMed article. This is the familiar cartoon that Dr. Asa made years ago, relating the families of the pituitary adenomas. You know, back in the day, we didn't have recourse to transcription factors or anything, and it was known that. So I've color coded them in the traditional format. The chromophobes were traditionally considered the gonadotrophs. The redder acidophilic cells were the PIT1 family, and the basophils were considered the TPIT limb. This is pretty useful in that, and it remains useful in that it really underscores the simplicity or relative simplicity of the corticotrophs and the gonadotrophs relative to the PIT1 family, which is where really people struggle the most, I think. But it's helpful to start by laying some groundwork that has to do with the normal anterior pituitary. Seen on the left, you've got a mixed population, a vaguely trabecular H&E on top, with an irregular trabecular architecture that's best seen in reticulin stains. Let's see if we can get this to pan out. Okay, it worked. That's good. Instead of providing abundant individual panels, what I've decided to do is put many of these images in as path presenter slides, again, so that you had your own opportunity to take whatever screenshots you like or to challenge my diagnoses and observations. But the point I'm trying to make with this path presenter of an anatomic or a sort of an autopsy pituitary gland is that they're highly variable. And yes, while it is true that ACTH tends to occupy a more central location within the gland, and that prolactin and growth hormone tend to occupy the wings, so to speak, it's highly variable, highly variable. And when you get a surgical sample of greatly fragmented things, you have to use other clues. You don't have the whole gland to help you. And notice here on the H&E, some of the striking inhomogeneity. For instance, here in the gap, the so-called intermediate lobe between the posterior pituitary and the anterior pituitary, the basophil invasion, for instance, these corticotrophs that are in an inhomogeneous array, if you will. I think that's useful when you consider. Good, we're back. When you consider what maneuvers to take when you were examining a putative pituitary adenoma PitNET in your sample. So that, for instance, it's helpful to know the staining pattern in normal anterior pituitary of the transcription factors. As a matter of fact, I rarely do a reticulin these days because one can use, when one does the transcription factors, the SF1, PIT1, and TPIT, one can use them as a rapid check on fragments, so that if the pattern is this, gonadotrophs decorated by SF1 in the upper right-hand panel are single separate cells, sort of distributed more or less evenly through the sample, that PIT1 is the majority, recognizing that that's the majority of the anterior pituitary, comprises the majority of the cells that are there. But notice that there are negative cells in the background, that PIT1 is not identifying every single cell. And that TPIT, the corticotrophs, are sort of a combination of single separate cells and also irregular clusters, and sometimes impressively irregular clusters, as was seen in the basophil invasion in the gland that we were looking at. Now, to make sense of a problem with so many variables, it was analogous to, and really much of the inspiration for the work that I've done in this field is provided by work like this, where what was necessary was an organizing principle to pull together seemingly disparate data. And in this case, it's very famous. This is Dan Bratt and the Cancer Genome Atlas Research Network, in a figure that I had this in every single neuro-oncology conference for years, to show how in this large group of diffuse gliomas, low-grade gliomas, how the organizing principle of IDH mutation and 1p19q co-deletion, along with things like TP53 mutation, ATRX, could be used to very clearly organize your thinking around not just the IDH mutant tumors, but to assail the idea of oligoastrocytoma. If there was a nail that put, the last nail in the coffin lid of oligoastrocytoma, it was this sort of argument. And it required this kind of powerful analysis. So I've always been attracted to this sort of work. At the same time, methylation profiling came into the world. And after leaving its origins in Heidelberg and in Germany, now we are familiar with this. We see the brilliant investigators at NIH, NCI, led by Ken Aldape, seen in this screenshot from one of the weekly conferences. Brilliant use of machine learning. I think we sometimes overlook in methylation profiling. We overlook the utility and the nuts and bolts of of machine learning in supporting this argument. Seen in the middle of the figure, in the green, the classifier, the methylation class and score, that is a supervised method, probably random forest. I don't remember exactly because there's other ways to do it. UMAP in the lower right portion is simply a dimensionality reduction method akin to principal component analysis or Tisney plots. But again, machine learning has really penetrated and is offering not just tools for what used to be esoteric data, methylation information, but I think it's relevant for our immunohistochemical scores, in immunohistochemical staining, if they are appropriately scored. So this is my chance to back up a little bit and tell you about what we did, because starting out, I didn't know which of the markers to bring in and why. So we started to collect information. We made tissue microarrays and finally assembled 157 adenomas. And with the help of Amber Wong, who provided materials from the University of Pennsylvania, they gave us about 20 cases. We had about 137. We made tissue microarrays and generated quadruplicate 2-millimeter cores. And then we're able to score those in a way that was, I think, still unusual in the field. And that is I was blinded to the diagnosis, to the serologies, to the sex, to the age, to any of these other features, and only had the question in front of me for an individual stain displayed here in rows. And in particular, draw your attention to the middle portion here of blue and light blue. Those are immunohistochemical stains that were used in this project, along with CAM 5.2 and alpha subunit. But without an organizing principle, notice how none of this makes sense. None of it makes sense. That it's colorful, it's pretty, but it doesn't give you a powerful sense of what's going on. However, when constrained by something as straightforward as hierarchical clustering, organizing the rows, which in this case represents immunohistochemical variables, and the columns, which represent individual patients, this is our 157. And so if hierarchical clustering is actually brought to bear, you see a pattern. You're now able to identify in your data the relative performance of many variables all at one time, and how those might impact the grouping, the clustering. You can speculate about how that affects the clustering. Now, there are other, for those unfamiliar with heat maps and their construction, you can see that hierarchical clustering was used because of the sort of the lines on top and on the side. We're organizing not just the rows, but also the columns here. And that really we are restricting this model to just these SF1 to ACTH, this series of immunohistochemical stains. I've left off alpha subunit for reasons we'll talk about later. But what this generates then is the ability to say, okay, well, what was our data set? What cases did we encounter when we pulled together 157 pituitary adenomas? There was limitations. These were predominantly macroadenomas because you had to get 4 quadruplicate 2 mm punches out of the material. So good luck doing that in a 4 mm adenoma, microadenoma. But so you can see this is an imbalanced data set. It is greatly comprised. Over half of these cases are gonadotrophs. They're dominated by the SF1 and the GATA3. They share LH and FSH staining down in the middle of the pack here, and are frequently estrogen receptor positive. We, as others, have shown that GATA3 is a frequent marker of SF1 positive gonadotroph adenomas, and perhaps this is cross-reactivity with GATA2. Regardless, it seems to be a more or less faithful marker of gonadotroph lineage, and others would indicate in their data that it's present in other tumors as well, I'd hasten to add. So in any case, these ideas have allow us then to really go back and forth between our case series and really to monitor carefully not just the composition of our population, but to make some guesses about the performance of the individual variables and their contribution. So what I'd like to do for the rest of the presentation is really to show you 3 different pituitary adenomas in each of the 3 families, and we'll get progressively more complicated. The most straightforward is this group, the gonadotrophs. This is just the definition offered by the WHO, with variable immunoreactivity for gonadotropins, and or SF1, an absence of PIT1 and TPIT. So in our shop, that means 3 markers are sufficient to establish a diagnosis of gonadotroph adenoma most of the time. It's the most common tumor in our cohort, and it's typically a non-functioning macroadenoma. So we'll see if we can get this. Yeah, okay. So this is a path presenter slide that shows off a typical gonadotroph adenoma. Notice how uniform the nuclei are, the oval nuclear outline, the finely dispersed chromin, the moderate amount of cytoplasm. It is also relevant when you're looking at your transcription markers in cases like this to find fragments where you see poor staining or irregular staining, and to return to those on subsequent stains to say, okay, well, was that just entrapped or adjacent anterior pituitary? And in cases like this, where you see a few staining cells here and there, but some cytoplasm staining, kind of unclear whether this is real or not. Let's explore that in the other transcription factors. Here, for instance, this is, I believe, TPIT. Oh, yes. And for those of you not familiar with Path Presenter, there's a little eye on the top left-hand corner, and you can click that, and you can find what the study is and some of the features of the age and the sex of the patient and some of the clinical information. In any case, this is a TPIT stain, which is showing some immunoreactivity in that region of adjacent anterior pituitary. So I think this is probably true. Now let's check that again. Let's check that with our PIT1 stain. And again, here are scattered cells in this crushed, sort of desiccated, cauterized portion of adjacent tissue. So this is not, it's helpful to continually look at your slides for pituitary, anterior pituitary that's included in addition to the adenoma, because there are times when focal staining is relevant, and other times it's not relevant. It's simply entrapped gland, and you can make that distinction sometimes on a good day when you've just got the transcription factors. Now, it's possible to conduct a thought experiment when you've got the data, when you've got all this immunohistochemical data scored using something I neglected. These were all scored with the all-red method, which is much more common in breast cancer, estrogen and progesterone receptor scoring. It's a simple scoring system that relies on both intensity and proportion. intensity from 0 to 3+, proportion from 0 to 5+, 5+ being 2/3 and above, 4+ being 1/3 to 2/3, 3+ being 10% to 1/3, and then et cetera, so that the higher the score, the darker the blue in the organized variables that are hierarchically clustered in this. I neglected to mention that, I'm sorry. But when one goes through that exercise, one also has to consider what true positive is. Or when one wants to estimate the sensitivity, for instance, of one's marker, it is equivalent to say, what is true positive, and how well does the test capture all cases of the disease in question? That's relevant because when you have the data in hand, you have to decide, is SF1 staining spurious in this group of PIT1 family members over here at the left that are strongly PIT1 family or PIT1 positive as well, and that typically were acromegalics? Is that out of bounds or is that in bounds? If you have a very strict definition of what true positive is and only restricted to the gonadotrophs, then you're going to have to accommodate that, or you'll have to ignore that, and your stain appears to behave less well. Then it becomes less specific, or less sensitive if the reverse is true. It's a game that can be played, but it's an important exercise because it starts to allow comparison of the various markers that might be relevant for gonadotroph staining. And in our hands, in both broad and narrow definitions of what true positive constitutes, SF1 is sensitive and almost as specific as the LH and FSH immunohistochemical stains. And that should be self-evident when you look back at the heat map here and see all of these markers that are negative, all of these gonadotrophs that were strongly SF1 positive or GATA3 positive, and negative for LH or FSH. LH and FSH wind up being very specific markers of gonadotroph, but not necessarily sensitive markers. So we've really replaced them with SF1 in our laboratory. And things like alpha subunit, on the other hand, coming back to that, to cut to the chase, it's present in such a variety of classes, and understanding that these families of tumors are porous, we decided that it was too unreliable to rely on alpha subunit as a standard part of the classification is in our algorithm, that I don't have a good role for that. So would refer you to other investigators with greater comfort and greater certainty around alpha subunit. I think that when it can be present in so many tumor types, it's very difficult to know, at least in our hands, it's very difficult to know how it might be useful in either confirming or refuting a diagnosis. In any case, we go through this exercise and we are relatively reasonably content that this is a straightforward proposition, that an SF1 positive, PIT1 negative, TPIT negative tumor is a gonadotroph, and we sign it out as such. The corticotrophs are slightly more complicated. According to the WHO, they're divided into densely and sparsely granulated tumors and Crook cell tumors. To make a long story short here, there are several features in the classification of pituitary adenomas that are seemingly bimodal. When one asks about sparse and dense granularity, one implies that there is a fence between them and that you can make that distinction. But in my experience, that's a tall order. That can be a very difficult proposition. So I'm not convinced that this is a distinction that can be made reliably. Crook cell tumors, I do make that diagnosis. It's a really characteristic pattern on a good day. But again, it really depends on the condition the tissue is in, how good your cytokeratin stain is, and whether there was excessive cautery or fixation artifacts and so forth. So to show you an example of that, of a corticotroph, we'll focus on this material. Again, this is not a mystery. You know, you would not need a reticulin stain even if you didn't use transcription factors to call this neoplastic. This does not look like anterior pituitary. You're really trying to rule out other things. So you do your stain. And if this were triple negative, you'd want to consider other diagnoses. But in fact, this is the T-pit with diffuse strong nuclear immunoreactivity. T-pit's been a very good performer in our hands lately without much cytoplasmic background. Better lately than SF1 and PIT1. Really happy to have brought that in. Here is the SF1 in that corticotroph, showing, again, a blush of background, but the nuclear staining is not there. We have a nice internal control that's starting to appear over here. See these single separate cells displayed like a gonadotroph background, anterior pituitary gonadotroph, but non-neoplastic population ought to be. And then here is the PIT one. And again, here is the adjacent adenoma hypothesis. Now, to the standard transcription factors, we always add ACTH and CAM 5.2, a low molecular weight cytokeratin. It functions well in our laboratory. This is as positive as our ACTH ever gets. And I would argue that it's probably at most 2+. But there are certainly better performers. This seems to be a relatively common observation among the corticotroph adenomas and ACTH immunohistochemical stains. Here is the CAM 5.2, our low molecular weight cytokeratin that we're using. The reason I really like CAM 5.2 in this setting is it's very, very uncommon. I shouldn't say very, very. It's uncommon for a corticotroph to be negative for a low molecular weight cytokeratin. And it would cause me to pause and really consider whether I was barking up the right tree if my CAM 5.2 was negative in settings like this. But in terms of judging granularity, again, I don't personally do it. I've provided in this Path Presenter folder PAS and PAS with diastase here. And I think this is probably a densely granulated example, but I don't typically make that distinction unless I'm forced to when I'm signing out these cases in real time. So the same exercise can be, in terms of estimating the performance of your stains, can be done, the same thought experiment. And this time, you know, we really have a more homogeneous group. It's not so split. There's not fine distinctions of narrow and broad definitions of what true positivity and what true negativity are. But that can be estimated in this way. And so we chose, based on this information, T-PIT is our real go-to with follow-on ACTH and CAM 5.2 staining because of its advantages in sensitivity and it ranks right up there with this in specificity with ACTH. Now, everyone agrees that the PIT1 family is the most heterogeneous and the most difficult to get our grasp on. But the good news is there are groups within it that are straightforward, the sort of monohormonal examples where the lactotrophs have prolactin and only prolactin as a hormone marker. They're PIT1 positive, but have only prolactin as their marker. Those cases do occur. Somatotrophs likewise have growth hormone as their marker. Now, there is a distinction between sparsely and densely granulated that's gotten somewhat more interesting. I'll show you some more information about that. I make this distinction. I think it's relatively straightforward, but I hasten to point out, sparsely and densely granulated, we're not judging granularity. For as important as nomenclature is in this field and sensitivity around nomenclature, we are really still reaching for terms that are derived from electron microscopy. But what we're really talking about are fibrous bodies and a cytokeratin CAM 5.2 or low molecular weight cytokeratin phenomenon used to distinguish between densely and sparsely granulated tumors when all you have is immunohistochemistry, right? So those are important ideas. I make that distinction, but I note that not everyone shows a survival difference between the sparsely and densely granulated or rates of remission here. For instance, this paper by Swanson and Company in 2021 did not find a difference in distinction rates. Nonetheless, I think it's worth making the distinction because I find it one of the more reproducible refinements on classification in pituitary adenomas. So I continue to maintain that. And then the thyrotrophs are so uncommon, I'm not sure I've actually encountered them. You certainly will see PIT1 family members with also TSH immunoreactivity, but as an isolated phenomenon, I think we have to be very cautious as we interpret data. We have to assemble enough of these cases in order to understand the behavior of our own reagents. This is work that I think is absolutely wonderful from Hamburg, Dr. Musch and Company, where they took a combination of densely granulated somatotrophs and sparsely granulated somatotrophs and found that the majority of the densely granulated somatotrophs actually, of their 52 were positive not just for the PIT1, but also for SF1, And some of those actually had some LH and FSH immunoreactivity at the same time. So orthogonal data to say that based on methylation profiling, based on as well as immunohistochemistry, that would suggest, okay, that the densely granulated group has at least 2 compartments, and that the more common has some features of gonadotroph. And they came up with a great term I struggle to remember, like a somatogonadotroph. Somatogonadotroph. That's totally cool. That's gnarly. Again, speaking to the porosity or the infidelity, some people say, between these lineages, right? Yeah, that's probably enough point to be made about that. But at the same time, WHO today contains another group that I would think of as complex or compound diagnoses, where you're relying on a little bit of this, not so much primary colors, so to speak, but a flavor of this, a little bit of that. You know, an acidophil stem cell should have a little more prolactin and the prolactin should outweigh growth hormone and might have giant mitochondria, and et cetera, et cetera. The trouble with these is their overlap and their uncommonness, that it's hard to draw crisp distinctions between them. And especially given, say, this work by Dr. Musch and Company, it's hard to know how this translates into the modern era where methylation profiling is being used. I tried to summarize these things by going carefully, line by line through the WHO classification and really abstracting the different markers and how they behave, and generated this little figure for pathology outlines a few years ago. And when you glance at this, you can take my word for it. The simple classes, the somatotroph, thyrotroph, and lactotrophs seem to be straightforward. But apart from that, there's so much variable, limited, minimal, some, occasional. There's so much qualifying and so many gaps in the rest of it that it's very difficult to say which entity is which entity without being an expert. And I'm not an expert. I am skeptical about some of the claims made by experts in these realms. But I think that morphology has long been known to be fraught in this area, and that we're looking for better ways to display the information and to sort these out. So while it's possible to, in the PIT1 group, feel really confident about a somatotroph or a lactotroph, the rest are more challenging. Really leading me to my fundamental. There's a whole from the free neuropathology paper that I it's just a letter. It was just a simple letter, but it lays out the argument in more detail on my criticism of the WHO classification as it stands. Really, it boils down to things like this, that we need to make very clear which features are classification features and which are just other variables that we're using to consider tumors. That if we make statements about that imply bimodality, that there are two peaks, for instance, that we should show that really maturity, acidophilia, granularity, if that's really what we're talking about, then we should show that it's possible that there is a fence between them and we can make a distinction, even not knowing the clinical setting, the serology, the radiology, and so forth. I think there are many, many overlapping features that complicate this, but my great concern is that the current PIT1 family classification is not falsifiable, that, which is something that's central to philosopher of science Karl Popper's idea that falsifiability is important in the scientific method. And it always reminds me of this quote from, there was a physicist, a quantum physicist, Wolfgang Pauli, who said, was criticizing a younger physicist who said, that's not even wrong. It's such bad science, it's not even wrong. Das ist nicht nur nicht richtig, es ist nicht einmal falsch. It's not even wrong, right? Because we can't falsify it. So again, I want to roll back to this idea that David Lewis has so clearly and elegantly stated before, and that a classification is an iterative process. And our job in the modern generation is to take what's given to us and then make improvements so that the next generation has less to work on. In any case, here is an example of a PIT1 family member that I thought was a lactotroph, but it was recurrent. And I think it illustrates some of the complexity without really going down a rabbit hole. So this should not be surprising. Here is the H&E stain section. Again, monomorphous. There's no question this is not just ordinary anterior pituitary. Here is the PIT1 stain. It is diffusely and strongly positive in the nuclei. We really struggle sometimes with cytoplasmic staining, but it varies with time. We had an antibody for a while until it was discontinued. That was wonderful. That was much cleaner than this, but this is still a reasonable shot. If you look at high power, the more or less negative endothelium, and the very strong nuclear immunoreactivity, that is characteristic of PIT1 family member. Conversely, addressing SF1 in this case, it was cleanly negative, and TPIT likewise cleanly negative in this context. Here's our prolactin. The WHO classification would sort things into sparsely and densely granulated prolactin or lactotrophs. I don't make a routine practice because I don't have a good control that would allow me to say, okay, here's the fence. It's on this side or that side of the fence. Here is, yes, this is an estrogen receptor stain, which is very frequently strongly positive, especially in younger people with younger women with the disease. But in this case, it's just wan, washed out. There's barely any here. And honestly, we tune our estrogen receptor to breast cancers, where sensitivity is the name of the game. And so I'm not sure that this helps or hinders our diagnosis of lactotroph adenoma and recurrent lactotroph adenoma, for that matter. This is the growth hormone, so comfortingly negative in this setting. And warts and all, our laboratory does make tissue with folds in it. I apologize. Here is the TSH, again, nice and negative. And then finally, this is a GATA3. There has been much written in the WHO about GATA3, but the actual amount of GATA3 immunoreactivity in PIT1 family tumors is, at least from our perspective and in our data, really quite overstated. That in our hands, we're not detecting GATA3 in PIT1 family members, and so this would not be uncommon. And then finally, this is the CAM 5.2, not showing any fibrous bodies, so I don't think that this is an acidophil stem cell adenoma. But in any case, these are this is a nice example of one of the simpler classes. When one crosses the line into more than one hormone and or more than one transcription factor, then we're in a new realm. So we did the same exercise in terms of putting these together. You know, the far left is occupied by the PIT1 family in this heat map. And see, we, like others, have found this SF1 positive, PIT1 positive population. That Dr. Mush has put so many together on. I think that I have not started to really use that idea and incorporate that, but I'm looking for ways to do so. I tend to be more descriptive, confronted with overlapping staining, and that seems to be adequate. Our patients get followed in a similar frequency. Honestly, regardless of where they're from, the other factors play a greater role in the variability in care that they get. There are cases here seen at the very far left that have very strong estrogen receptor staining. Those feel great when you make a diagnosis of those, where it's just strong PIT1, strong prolactin, strong estrogen, and nothing else. It's wonderful. It's clean. It's easy. It's simple. So some of those will be straightforward. It's really the acromegalics and the overlaps where one has to slow down and really think carefully about how what you're seeing may or may not relate to the current WHO classification. You can do the same exercise in terms of the immunostains. And then especially in this where there's limited data, this is more or less an exercise to show that there's the smaller the numbers, the greater the variability. So for instance, if you focus on the sensitivity of a narrow definition of TSH immunoreactivity, look at how wide this error bar is because there's such a small amount of data involved. So it's a signal that we don't know as much as we think we do, I think, as we also, or as we would like to know about the behavior of our immunohistochemistry in these contexts. So, you know, we're coming closer to the end here. I still don't know how many classes of adenoma there are in the world. That was the question that got the ball rolling for me. How many are there, and how do we know? Methylation profiling, the Heidelberg latest classifier, has just these 7 entities: ACTH producing, gonadotroph producing, prolactin producing, those are the lactotrophs, and then 3 flavors of the somatotrophs, 3 flavors of the growth hormone tumors, including the densely granulated, the 2 types of densely granulated that were observed by Dr. Mush and company. And then the final one being the TSH producing, which again is rare. So we should also mention null cell because it's a thing. Fewer and fewer null cells happen because we have more and more tools to characterize the different lineages. Let's see if we can get this to work. I am hoping we can. Really hoping we can do this. So this was on our first paper or second paper, and it's the same data that was displayed in the heat map, but it's simply a t-SNE plot showing it's mouse overable, so you can see how the immunostains reacted. But suffice it to say that most of these are gonadotrophs, but further out on this gyre, on this limb, is the strongest immunoreactivity for SF1 and for TSH and FSH. And as you approach this area over here, this is the null cells. Likewise, the same phenomenon happens in the corticotroph group to the far left corner, where you appreciate a diminution of ACTH as you get closer to this. And I don't know whether the PIT1 family contributes to this meaningfully or if you would see that ultimately, but suggesting that perhaps the null cells are really just a final common pathway, mostly from gonadotrophs probably also from corticotrophs and perhaps too from PIT1 if we can assemble enough cases, but we don't know for sure. So so they still occur, and I still encounter them, but less and less frequently. So to be provocative and really just circle up, getting ready for questions now, I find PitNET personally a cumbersome term. I don't see a real reason to change it. The Gulf of Mexico is the Gulf of Mexico. Sorry, I don't know what point you're trying to make. I know what point you're trying to make with by changing it to the Gulf of America, but I respectfully disagree. I think that photomicrographs have been sort of abused in this field where they're considered evidence. They're illustrations. They're very light evidence at best. We need to do more. We need to score our work. I think that we still have this legacy of ultrastructural observations and of kind of fly by the seat of your pants classification. I think we can do better. I think we can state the variables in advance that we're using for classification, and that classification ought to be falsifiable, because then you can make useful changes to it. I think that the simpler variants of statistical learning and machine learning are absolutely essential in this regard, and let us see things and patterns that we have not otherwise been able to see. I think, unfortunately, the world is divided into clubs, literally into clubs in this area, and I think that's pernicious. And that the greater attention we have to the classification problem itself, just the nuts and bolts, whether it's applied to pituitary tumors or elsewhere, the better we're going to be able to understand and classify our tumors, just period. So lots of people to thank. But the most important one is Dr. Kelsey McDonald, my wife, who got me started on our programming bandwagon years ago, and then just sort of abandoned it to me. I did all the mistakes in this presentation, including the coding, are mine. The collaborators at Alina and at our partners at other institutions, including the University of Illinois in Chicago, Andre Bala and Vicky Macias. Also, Amber Wong from UPenn has been very helpful. And then I get to work with a wonderful pathology resident, Zeynep Timeret Koum, who is here in Minnesota now and is looking for a residency spot. Any program that gets her is just going to be delighted. She's fantastic. And then the person who keeps the lights on for research at Alina, and it's tenuous sometimes, is Marie Meyer. And I'm deeply grateful to her untiring just efforts in supporting the neurosciences. So I'll take any questions and
Thank you so much.
criticism.
That was awesome. Thank you. So at this time, we're going to move into Q&A. You can submit your questions via the chat box, or you can unmute to ask a question. When you submit a question via the chat box, please ensure the message is to everyone so that the presenters and attendees can see your question. And to unmute, select the microphone in the left lower corner. And once you've asked your question, please remute. Oh, there's a big long question from John Donahue. I'll go ahead and read it. I've called around to different institutions around the country, and there's no standardized approach to working up adenomas. Some groups get transcription factors up front and hormone IHC only if necessary. Some get hormone IHC up front and transcription factors only if necessary. At least one gets everything up front every time. Do you ever order hormone IHC routinely? Why can't we establish a national or international standardized approach for these cases?
That's exactly the point. Yes, yes. And I think that's wonderful. That's wonderful. And there's much misunderstanding around this. We made this 3-stain sort of screening panel, PIT1, SF1, and TPIT, to serve the majority of tumors because they were well served that way. But let me be specific about that. Whenever there's a clinical history of function, whenever there's any discrepancy in the observed immunohistochemical staining at all, then we enlarge the panel. And so for the Gonadotroph seem to be manageable with just the transcription factors, the Corticotrophs with the addition of ACTH and CAM 5.2 in our hands, and then the PIT1 family, pretty much the whole mess I'm reconsidering. We don't usually use LH and FSH these days in that context, but there's an argument to be made that that's also useful. It will require collaborative efforts, and really the people who recommend everything every time, the whole panel every time, really need to stop publishing these papers where they're only giving you one variable on one entity, and the entity is rare, and the variable isn't really clearly stated. That, you get a small smattering of weak staining, and that constitutes real staining. No. We've got to put this in a more blinded fashion. And I'm eager to help and to collaborate with people. As a matter of fact, you could reproduce what we did. Any of you institutions who are using whole slide imaging now could reproduce it without making tissue microarrays by simply extracting patches, 2 millimeter circular patches like a punch from the immunostains, putting them in an unidentified fashion, or identifiable but coded fashion, into a bucket, and then having your expert sit down and scoring that for intensity. You could answer questions like granularity, dense or sparse. You could answer questions like, well, how much staining is necessary. You could automate it. You could make it machine read. The DNA methylation classifier, I see, so yes, I do. So to finish up on John's question, yes, I do the hormone markers, and they're invaluable. You got to use them, especially in the PIT1 and especially in the PIT1 family. Is DNA methylation classifier a better method to group the adenomas? That remains to be seen, doesn't it? That's orthogonal data. But my question is, if there are so many fine groups in the current PIT1 classification, for instance, why aren't they showing up in the methylation classifier? They've had quite an amount of time now to find subtle patterns and accrue small clusters, small clouds in those TISNEs or UMAPs or whatever. But we haven't seen that yet. So I think it would be a shame to have to rely on methylation profiling when we've got what could be a robust system with immunohistochemistry only. It's fast and cheap. We're accustomed to it, and a pathologist doesn't have to wait so long on it. But yes, I'm a big fan of methylation and just the philosophy behind using that. What is the clinical implication of doing a better classification? It seems that neurosurgeons are not very interested in this kind of classification. Believe it is their accomplishment to remove as much tumor as they can. This gets back to, we always lead the field, and surgeons, we pull along kicking and screaming. You're right. What is the outcome at the end of the day? And I think only if we have a reliable classification can we really, why are there no, or precious few, it's like a handful of Kaplan-Meier curves in the whole field? Because we can't come up with a reproducible classification that would allow us to make reasonable comparisons in outcome, right? So I think it's on us, if we want to compare apples to apples therapeutically in terms of prognosis, in response to therapy, we need to do a better job. Is there any factor or marker that we can study that could predict the behavior of these? Okay, there's a great history in this, and a valuable lesson. P53 was used along with Ki67 staining to identify atypical adenomas for a generation, and then was abandoned because people weren't interpreting the same thing. They weren't comparing apples to apples, and they were relying on a very small fraction of the tumor actually staining for P53. And go figure, now we've got more experience with P53 immunohistochemistry, especially with the IDH mutant astrocytomas. And we see variability in this pattern just as a baseline. So I think, we're looking for that. We're looking for factors that can help predict these markers, but let's get the data and show that it's a reproducible class that then shows a difference in prognosis and prediction. Many are not even operated anymore, treated medically. Yeah. Medical treatment is improving for these, although depressing things happen. People either can't tolerate cabergoline or afford it. Apparently cabergoline to target lactotrophs is expensive. And so we've had at least some patients who could afford bromocriptine, which apparently has a worse side effect profile or something, has some feature, I don't remember. So yeah, we see a lot of macroadenomas, and centers with lots of macroadenomas like us tend not to see the functioning smaller tumors that and have as much of a conversation around medical therapy. Okay, ATRX, I have less experience with ATRX. I'm interested in pursuing that, but I don't have good experience with ATRX in this. I've seen some of the work that's done there. I'm married to a geographer, so the Ki-67 proliferative index question really reminds me of some of their struggles in sort of how do you take a sample of a neighborhood, and because you can be guilty of gerrymandering, so to speak, on a tissue slide. So I think you have to be very cautious, and we haven't closed the books on a rational approach to Ki-67 yet. Yeah, and aggressiveness. You know, we have tools. We have tools. MRI is a fine tool, and when that tumor is wrapped around both carotid arteries and is towering up and compressing the optic chiasm and wrapping around important structures, that's valuable information. One of the most important, I think, recent developments is out of France and Chiara Villa's group, where they started to take what they called it a pangenomic approach. But what they did, the math that was clever was they started to compare unlike data. So they were taking numeric and categorical data and combining them in a mathematical fashion, opening the road to things like, well maybe it's serology that's the important factor here. But we're in such a narrow lane, and it used to be EM that we were constrained by. Now it's immunohistochemistry. Why be so uncreative? Why rely on only those things that happen in a pathology laboratory? MRI will be a valuable resource, but serologies and standard endocrinology could also be encoded and put into models that would better stratify principle or theoretically. So anyway, that's about all I know. Are there others that I've missed here? There was a list.
I think you got them all.
Did I? Okay. We're getting close to the top of the hour. And no, seriously, I think that there are investigators in Australia, in Europe, in North America, who are not well represented on the WHO committee. I think that, oh, this is terrible. I almost forgot. B. Lopez is our greatest resource here. She is representing us still in these committees. And is fighting the good fight. She's really done wonderful work, and is at times been put in a very awkward position. She's also the only person to ever call me out in an international meeting and say, "I disagree with Bill McDonald," which was awesome, which was so cool. Anyway, B will have great things to say about this, and I'm looking forward to. I don't have direct communication with the WHO committee. I do with some of the guideline stuff that's happening right now, but we'll see how this conversation evolves over time. I hope that more voices from Sydney, from Germany, from Paris, and from the rest of North America can make themselves heard on that committee.
And then I think we have one more question. Sarah Stone has her hand up. If you can go ahead.
Oh, okay.
Can you hear me?
Yeah. Yes.
Thank you for this great talk. I really appreciate your approach with just curiosity to this very confusing area. And I think it makes a lot of us probably feel a lot better about our struggles with classification of these cases. But I just wondered if you could comment on acidophile stem cell tumors in particular. Do you think they're histologically identifiable? There's so little data published about them. I just particularly struggle with that diagnosis and the mixed PIT1 lineage.
I do too. Amen. I do too. And I don't know. The answer is I don't know. You know, you look at criteria like giant mitochondria, and if you go back to those original papers, even giant mitochondria were absent in about a third of those original papers. So what those cases were that lacked them, I don't know. And so anything predicated on identifying giant mitochondria, including immunohistochemical maneuvers, or observing in tissue sections the vacuole that's supposed to represent the giant mitochondria, are questionable. So I don't think until you sort out some of the other, separate some of the wheat from the chaff, it's very difficult to answer that. And the more we can convince the folks who have recommended do everything every time to actually give us that data, to actually score in a blinded fashion that data, and then release it to other scientists. And by the way, all of our data now is available in the free neuropathology stuff. You could download the CSV and have fun and using machine learning, add it to your own series. Please do. I'd love it. I'd love it if you add it to your own series and just, you scale it, whatever way you're quantifying your immunohistochemistry, fine. There's just a scaling. That's just a simple R maneuver.
Thank you so much for your comment.
And then you got a bunch of thank
Able to
yous
hear me?
in the chat.
You're able to hear me, Dr. Oviedo? Okay, sorry, I was having some mic issues. I was just going to do the wrap up. Were there any additional questions you were saying, Dr. Oviedo?
No, I think that's it. It's just a thank you. There's a lot of thank yous, and I'm saying thank you.
Awesome. Well, thank you again for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your Path LMS screen upon the conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. Once you have completed the evaluation and selected your credit amount, please then select the appropriate certificate based on your credentials. The PowerPoint slides and recording will be posted to the AANP website in the next week. Thank you again to Dr. McDonald for an excellent presentation. This concludes the session for today.
Bye, everybody.
No,